methods to overcome all these problems faced in such populations. Wide varieties of changes has been seen after after long 2 decades, but still there are so many concerns which are facing by the population. Next comes the optimization of drug in pediatric patients. So optimizing the drug in pediatric patients, as we already said, like there are changes in the bioavailability, pharmacodynamics, pharmacokinetics, efficacy, adverse drug effects in the pediatric populations completely different from the adult dosage data. And we said like it depends upon its disease state, organ function, and efficacy. So finding out an optimal dosage for the pediatric patient is not at all easy. So we can find out what are the methods which is easy for the patients to get out of the disease state or make the drug more efficient, effective for the patients. Here, several additional factors should be considered in optimizing pediatric drug therapy. Many drugs prescribed widely for infants and children are not available in suitable dosage forms. That is one of the main concern. Second is, for example, extravenous liquid dosage form of amiodarone, captopril, omeprazole, spironolactone are prepared for infants and children who do not swallow tablets or capsule. And injectable dosage forms of aminophylline, methylprednisolone, morphine, phenobarbital are diluted to accurately measure small doses for infants. Then, because of low fluid volume requirements and limited access to IV sites, special method must be used for delivery of intravenous drugs to infant and children. Usually for the sudden systemic action, if we need, we will be giving the dosage form IV way. But in infants, neonates, it is very hard to find out the IV files. So it is a really big concern to find out a way to administer the drugs in such small patients. Then comes as simple as it may seem, administration of oral drugs to young patients continues to be a difficult task for nurses and parents. Similarly, ensuring adherence to pharmacotherapy in pediatric patients poses a special challenge. So, drug regimen and pharmacotherapy plays a crucial role or possesses a special position in the making of optimal dosage for the pediatric patients. Enormous progress has been made in pharmacokinetics in pediatrics. Two factors contributed to this process. So we can find out what are the two enormous progress that has been made for, especially in this field, in pediatric field. What are the progress that we made? First one is the availability of sensitive and specific analytic methods to measure drugs and their metabolites in small volume of biological. That is the first enormous progress that we made as far. That means we can specify the availability of the drugs through analytical methods, and this is very good for optimizing the drug dosage form in the pediatric population. Second one is awareness of the importance of clinical pharmacokinetics in optimization of drug therapy. Absorption, distribution, metabolism, and elimination of many drugs are different in premature infants, full-term infants, and older children. First, we can pass to the absorption. Two factors affecting the absorption of drugs from the gastrointestinal tract are pH dependent passive diffusion and gastric emptying time. So both processes are strikingly different in premature infants compared with the older children and adults. In full-term infant, gastric pH ranges from 6 to 8 at birth but declines to 1 to 3 within 24 hours. In contrast, the gastric pH is elevated in premature infants because of immature acid secretion. Thus, the drug with limited absorption in adults may be absorbed efficiently in a premature infant because of prolonged contact with the gastrointestinal mucosa. So here it is mentioned that absorption GIT Here it is said like two factors affecting the absorption of drugs from the gastrointestinal tract are